Right. So good afternoon, everyone. So we are going to start the post-lunch session on day one. We are slightly behind the schedule, so we need to start right now. So this session is going to be country presentations. So why we are having this session on country presentation is for all of us to know what exactly is happening in the countries that are represented here. Because I know, like, we all know countries are different to each other, but there are so many things in common. So this is the time for us to hear from the countries, the ministries, what they are doing. Bit of housekeeping rules. So each presenter will have 12 minutes to present, and which will be followed by 2 minutes of Q&A. Okay, so we have a timer here for all the presenters, so that unfortunately we will have to force you to finish your presentation to accommodate everyone, because we have a very tight schedule. So you will only be allowed to present for 12 minutes, and it is indicated here, right? So we have 6 countries presenting today, and we will start with Pakistan. So we have a couple of representatives from the Ministry of Health, Pakistan. We have Dr. Sabine, Dr. Hassan, and Dr. Andre. All of them together will be doing this presentation. It's my honor to invite all of you to the stage, please.
Dr. Essen has gone for his prayers, but I'll try to stay within 5 to 6 minutes so that Andre can join in. So I will be more talking about what we have done regarding especially the integrated disease and surveillance module based on HIS2 platform. And I will be talking more about it. And then the Andre will be giving you a bigger picture of how HIMS overall and the support that we are getting from the partners. So without further ado, I'll be very quick. So you all know Pakistan, 4 provinces, 3 regions, 5th populous country, high population. Okay, I'll put that. Okay. And most of our population is a young population. So we have been facing a lot of challenges lately, and where the health system has its own challenge, we are also, there are external stressors on the country. Like I said, we are the 5th populous country, high population growth rate, double burden of disease. Then post-COVID, there's a lot of macro fiscal limitations. And then disasters. We recently faced the most devastating floods in the history of the country, where more than 2/3 of the districts were hit, and in more than 50% of the district, all the healthcare facilities, be it a community level or a facility level, all were destroyed. Then the geopolitical conditions and things like that. And then there are health system challenges, especially I think the colleague from Sri Lanka, the Professor Saab, was talking early this morning about brain drain and lack of human resource. And unfortunately, if you look at WHO EMRO region, Pakistan is one of the country which is seeing the highest brain drain. And at the same time, we have a breadth of skilled HR, especially specific to IT and information technology and things. There may be information technology people, they are public health people, but a public health with information technology knowledge or information person with a public health, that kind of a combination is trivially less in the country. Then we have a huge private sector, and then there are few particular programs that we need to integrate and linkages. And then, as you know, health is a devolved setup in Pakistan. So there is a different provinces are at different level of implementation. So IHR, you all know, Pakistan is also signatory, and it's a legal binding on all the member states of WHO. So Pakistan underwent its first JE. We were first in the region, and I think second in the world for the first tool of the JE in 2016, and where there was a strong recommendation to develop an IDSR system. Based on that, with the support of UKHSA at that time, we developed a whole document based, this is just a snapshot of it, the three-pillar approach, where we have infrastructure, core function, and support function for introducing IDSR in Pakistan. So we have then established dedicated teams, both at the federal level. NIH is the main lead, which is an autonomous body under Ministry of Health. And then at the provincial level, there are DDSRUs and sector, and there is a whole infrastructure has so far been developed. So I'll quickly take you through the journey. So after recommendation in 2016 and development of the document, 8 priority communicable diseases were actually piloted in 7-8 districts in the country. And then based on the findings, the standard case definition, outward threshold developed, training manuals were developed, data reporting tools were developed. And this was all based on DHIS2 module, and then training was conducted across the country, the master trainers and then the TOTs. Initially, it was started in 8 to 9 districts, and then it was a gradually expansion. At this point in time, about 139 districts has been trained and are now reporting on 33 priority communicable diseases. There is aggregated data reporting in DHIS2, data server established, and there's further training of more than 8,000 healthcare personnel on data collation, analysis, and risk assessment, and all the paraphernalia required. Currently, we would like expansion to the remaining districts. There is an MNE weekly review meetings to improve on what is being done. There's always an improvement on what then. And then linkages with professional labs and sentinel sites. And then there's a need further to being an evolved setup, we need to strengthen our coordination. In NIH, whatever the data we are receiving from the 139 district, issue a regular weekly bulletin of epidemiological things that we see. At the federal level, we have developed what we call a planning document, a planning commission document, or you can say the proposal to get government funding. And the federal government areas, these are the ICT, AJK, and GB, are fully funded through that, and where the IDSR is being implemented through pure GOP funding. This is the flow. Given the time, I think you can all look at it. And then this is how the reports of the weekly bulletin come in, and this is the latest 44th week report of various suspected cases during the week 44. The way forward would be that there should be more sustainable government funding. It need to be rolled out in the remaining of the districts. We have total around 160, 165 districts. DDSRUs are present across all districts, and these disease surveillance units at the district level need to be operationalized. As the things come up, we were having a very nice presentation earlier where the new things are coming up, and we need to continuously do training of the new people who joins, and then the refresher of the rest. Then inclusion of the event-based surveillance, strengthening of response component in public health perspective, capacity building, linkages with animal sector and One Health approach, and in integration with the vertical programs, especially the ATM programs, which are already using the DHIS2 platform. So I'll stop here and I'll give floor to Andre. Forward. Thank you very much. I'm happy to respond after.
Yeah, my name is Dr. Andrei Tulisov. I work as a health specialist in UNICEF Pakistan, and I'm coordinating DHIS2 work and digital health work in UNICEF office in Pakistan, country office UNICEF. And we are closely working with Ministry of Health, all the partners and provinces. Pakistan is quite a complex country in this sense because you have quite decentralized health system. federal government is represented here. We also have representative from the provinces, but the financing mechanism is decentralized. So sometimes governance mechanisms are also not very straightforward. So practically to implement DHIS2 in Pakistan, you have to deal with at least 6, if not 7, 8 entities. And you have to do bilateral collaboration with all of them if you want to be successful. Approach for UNICEF is also to go for more unified system, which will be covering the whole country, so that all the provinces are reporting on the same indicators with the same modality. Thus, we, ministry together with the provinces, actually with our support, came up with a list of core indicators which are being reported through HMIS all across the country. But also provinces and territories can choose their own indicators on top of this. So this flexible approach was also quite efficient in terms of giving certain freedom to the provinces so they can incorporate their own indicators. At the same time, we have a comprehensive picture all over the country. So UNICEF started this work in 2018-19 with BMJF funding. It was part of the big project on pneumonia and diarrhea. We started with 2 provinces, Sindh and Punjab, which are the biggest provinces. Punjab is probably half of the population of the country, around 130 million people, and Sindh is about another 70 million people, so it's quite a big territories. And it came quite smoothly in Punjab. They were better prepared, they were more motivated, there was commitment of the government, and eventually they did quite great job, and DHIS2 was rolled out all across Punjab in 2021. While in Sindh, there were some challenges and we are still trying to get it through. We also have quite substantial progress in the province of Khyber Pakhtunkhwa, which is, if you are not aware, is bordering Afghanistan. It's quite also a complex working environment. We have people from this province, thank them for joining us. And there were a lot of issues and challenges there. Access sometimes is a problem, but eventually it seems to be that province is moving quite well in DHIS2 implementation. And together with HISP colleagues who were very instrumental and very helpful to us and did a lot of extra work, we actually managed to go through the implementation in KP. And at this stage, we are at the final stage of pre-testing, which should result in a rollout early next year of 5 districts, and then the rest of the province is supposed to be covered 2024, probably a little bit 2025. Balochistan, that's another province in Pakistan, which is bordering Iran, Afghanistan, and has also a seaside. It's also quite an interesting environment because it's more deserted, less people. Communication is also quite difficult. And capacity is also probably less than in other 3 bigger provinces in the country. So we did also quite substantial work there, but we have a very motivated team. We have Dr. Dawood with us, who is actually representing this province, and they really did a great job. We made the launch on the request of the government in 2 weeks ago, I believe, right? So and then there was quite good training conducted by HISP Pakistan and Islamabad. So practically, I think that this province will be quite a champion in the next couple of years, but I think they will be doing quite good progress in this year and beginning of next year. The approach is more or less the same. So now there are 5 UHC, which is Universal Health Coverage Prioritized Districts in Balochistan, which will be rolled out. But we also have some commitment from World Bank, Pathfinder, and I believe there will be also other partners, and UNICEF is also committed to support further rollout. So we hope this province will be also converted to DHIS2 fully in 2024. Yeah, other districts, as I mentioned, right? I mean, we have we have also territories up far north, which is Gilgit-Baltistan, Azad Jammu and Kashmir, and there were quite a lot of challenges there, but we are also going to implement that. So what is the way forward? in Pakistan is a big challenge is the private sector. It's not a big challenge as such, but it's a big challenge for us for data collection because 70% of all the services are being provided by private sector. It's to a very big extent excluded from data collection. So we want to get them on board. We also have quite an intensive discussion how to integrate EMR. We also have capacity issues, which we are going to invest now, including the higher management. Integration is an issue and different with different kind of components. We also have a module on nutrition, which was also supported by UNICEF and is being implemented all across the country, and it will be following the pattern of health. And we also have a module on identifying the causes of neonatal mortality in order to put in action. That's another initiative which is UNICEF supporting, but we are working closely with the ministry on this. And yeah, challenges, fragmentation. I could give you an example when we did an assessment in Singh, 34, 36 different platforms of data collection, not speaking to each other in public health sector. So just give you, I think that you will see many similar situations in other countries, but it was like shocking to me because each of these platforms has resources, they have money, but eventually they don't contribute to the overall infrastructure of data collection. So that's what we were saying, money is in the country, it's possible, donors are happy to contribute, but coordination mechanisms need to be ensured, both on the government level and with the decision makers. And with the decision makers is the government, but also with the donors. Yeah, I mean, we need to have dedicated staff, there should be logistics, infrastructure, and yeah, the country is also, as we are sometimes saying, Pakistan is in the constant status of response to different kind of disasters and emergencies, right? We always have something, you name it. So practically, it's also quite an interesting environment in this sense. We always have, but I mean, it's also an opportunity because it gives you some funding and some possibility to build on this. Thank you very much, and sorry for.
Right. Thank you so much.
Yeah. ICT is Islamabad capital region, which is actually the 7th region, Pakistan. Yeah.
Right. So thank you so much for that very comprehensive presentation from the biggest delegation we have here. I think we have more Pakistanis here in the hall than the Sri Lankans. So thank you so much for coming. Yes. Right. So next I invite, unfortunately, we don't have time for any questions. Yes. Please, may I invite the Ministry of Health from Nepal to present their DHIS2 implementations.
Good afternoon. Good afternoon, everyone. I am Deepak Dal from Ministry of Health, Nepal. First of all, I would like to welcome from the country, my country, Nepal, the highest peak of the world and the country of the birthplace of the Lord Buddha. Yeah, I'm going to present in brief. We have only few slides, so I'm going to present right now. Please. Okay, I will. Okay, thank you. My outline is, I'll explain about HMIS Nepal, what is the background. Then adoption of DHIS2 for Nepal, HMIS, customization and migration. We have already adopted DHIS2. Current status of the DHIS2 implementation, where we are right now. DHIS2 continuation upgrades, opportunities and the challenges and the way forward in few slides. Now, Nepal is a federal, we adopt federalism in Nepal. We have federal government, provincial government, and the local governments. Under federal governments, we have Ministry of Health and Populations and departments, councils, universities, and the territories, hospitals in the federal level. And besides this, we have the provincial government. Under provincial governments, there is different divisions, provincial directorates, provincial laboratories, and we have 77 districts, 77 district public health offices under provincial government. Similarly, in the local government, we have 753 health units right now, and other primary health hospitals, health ports, basic health units, community health units, these are under the local government. Thus, we have the federalism in the Nepal, and the federal government, provincial government, and the local government. In all the governments, we are using DHIS2. Now I'm going to explain in one slide the historical background of health management in information system of Nepal. HMIS is established in the 1993 in Nepal. That time, there was no, we did not adopted DHIS2 that time. In the initial stage, we had paper-based system, paper-based recording the reporting system in the initial stage. Then gradually we improved, and in the 2007 and 11, we use piloting to improve the HMI system. We adopt pilot. 3 districts we select for piloting. That is the Lalitpur, Parsa, and Rupandehi districts. That HSIS, Health Sector Information System, was the upgraded system of HMI system. So we adopt in the 2007 and 11, 7 to 11 in 3 districts. Then we started online data entry district integrated monthly reporting system in 2014. Then web-based online data entry in 13. And similarly, major tools revision. We have a huge tools revision in the 14 and 16. We online reporting in DHIS2 in 2016. We adopted 2016 from district health offices, from 77 district health offices. Then in 2018, we have HMIS online recording reporting system in DHIS2 platform from all local level governments, that is 753. Right now, we are using in all the, throughout the country, we are adopting. We have already adopted our DHIS2 system. We are adopting the right now. Now, HMIS online directly reporting in DHIS2 platform, more than 3,300 health facilities right now. Recently, major HMIS tools revision done in the 3rd time, and started receiving data from this fiscal year. This is started right now from this fiscal year. HMIS is a large and a core routine web-based information system, and that has been put in the place by the Ministry of Health and Population. And it's a Health and Population, Ministry of Health and Population focus our HMIS system, which prioritize HMIS system in Nepal, and it captures the health facility-wise information on all service delivery points, public health activities, morbidity, mortality, OPD and IPD services, surgeries, and diagnostic services, etc. Health facility is a primary data generation point. SF is the from we provide the service from the health facility. That is the primary data generation point. That is the generation point. Monthly, more than 10,000 health facilities reporting in the system, where there is the public and non-public also. Using 73 different types of, we have more than 73 recording the reporting tools. And using these different types of recording reporting tools and the monthly monitoring sheets in the system we are using. Regarding the adoption of the DHIS2 as HMIS backbone. Now, revision in the RR tools required as a scalable software platform 12-13. Joint feasibility analysis, we did joint feasibility study conducted in the MHP, GIJ, WHO, University of Oslo, and the HISP India support of. We did joint feasibility analysis and customization supported by the HISP India with national experts. Then various capacity building activities we conducted. We conducted the trainings regarding DHIS2, the health of different MHP, GIJ, WHO, Oslo, HISP India, etc. Various capacity technical supported by the GIZ and other development partners in Nepal, and full migration in the November 20. From 2016, we have the full migration in November 2016, and we are using the version V2 2.23. Now, current status running, we are using the 2.30 version in Nepal. Still, we are very back now, but it is progressed much more. We are still in the 2.3. Adoption with the federalization of the country. Now, I have already told that we have the federalization. Large scale adoption with major reporting tools revision in 2022. We revised our tools as per need of the program divisions service, and provision and authorized certain administrative rights Right? Users at all level, 4,500 SFs, 75 local units, and the 7% at the national level. Now we have more than 500 indicators in the system, and 9K plus health facilities we have, and 4.5K data elements, 8K users, 25 plus data sets, and the 130 M plus data valuers right now in the system. Really, we have some opportunity and challenges also. Now, DHIS2 much flexible platform, experience of the COVID-19 data. During the COVID-19, we used the DHIS2 platform. That was, I think, that was the only supportive platform to capture the data during the DHIS2. It is very useful and helpful for the Nepalese government to collect the data, analyze, and use. And growing DHIS2 community, it is gradually growing in country, customized, and it is free and open source software DHIS2. So we can customize it as our need. We are customizing it as our need, and it is very, I think, popular in Nepal. Yeah. Wider interest on open source software within the MOSP, HMIS roadmap. We have the roadmap, integrated health management information system, where we go after 1 year, 2 year, 3 year, or 2030. Because we have the already roadmap, HMIS roadmap. For this roadmap, DHIS2 is supporting to collect, analyzing, and using the data. Now, strong data flow network we have existing at all level. I've already told that we have the local level, provincial level, and the federal level. We have the data flow network, standards, and the interoperability lab within MISP. Yeah, we have the interoperation. We have different service divisions we have. So right now, I'm under Ministry of Health, and right now I'm working there in the NTP Nepal. So the NTP Nepal software is interoperable to the HMIS system. The platform is same for NTP Nepal and the HMIS, only DHIS2 platform. We are, NTP Nepal is also working on the DHIS2 platform, so it is interoperable to the HMIS. Now there is some challenges also. All of we know that we are mountainous country. We have very remote health facilities in the mountains. So, and other unique calendar. We have a Nepalese calendar, Nepalese fiscal year. We tell it Arthik Varsha, you know. So now for the Nepalese calendar, it is difficult to us, but it's also support us for this. So we are pitching the Nepalese calendar in the DHIS2 also. Yeah. Never-ending revision. Our revision is gradually, it is upgrading process. It is revision and the emerging reporting requirements in health sectors. IT infrastructure, I have already told that the IT infrastructure in the remote health facilities, it is right now, it is also inadequate. So we have to expand IT network in Nepal in the remote area right now. Digital literacy among healthcare workers here. Digital literacy is also necessary. All the health workers are not digitally literate for the DHIS2. So our package, the training to the government is have the priority to train those staffs who are not IT literate. Now, regarding the work forward, scale out to all health, we are scaling up in all health facilities under the local levels of few remote area facilities. It is not still it is not scaled out. Few facilities, but they are reporting. Yeah, any local governments, those health facilities where the DHIS is not using, they come to their local authorities and enter the data. They are entering the data. They are pushing the data to the DHIS2, but they do not have IT infrastructure. They come to the headquarters of that local body and enter the data to the system. That we are doing there. Now, continue upgrades of DHIS to newer versions. Yeah, it is a general process. Continue expansion of in-country capacity. I've already told that government is focusing in IT. So we are continuing to IT training with those health workers who did not get. Country community for digital health. Engage academia, all the academia. We are engaging the academia and promote standards, best information system with interoperability features, improve data quality. I've already told about the interoperability. Thank you. This is my presentation. Thank you. Thank you very much.
Right. Thank you very much, the team from Nepal. So finishing on time. Yes. Do we have any questions? Because we have 3 minutes left for Q&A for Nepal. Are there any questions? Yes, we have one question. So maybe you can use this one to answer. Huh?
Hello, my name is Intan. I'm from Indonesia. Such a good presentations for you. Congratulations. Maybe just one questions about the regulations. Did you make the regulations so that the implementation of the HIS2 implementations well in your country? Do you make regulation or SOP or some things like a policy so the implementations well for use the HIS2 platform in Nepal?
Thank you for the questions. Yeah, we have our digital health policy, and all the service providers, health service provider, all the institutions who provide the health service, that should be report within the 7th of next month. Those health facilities who are providing a health service, that health service data should be present, should be entered in the DHIS2 within 7th of next month. This is our policy from the government of Nepal. So DHIS2 accept the data from our service providers. Thank you. Thank you.
Thank you very much. Any more questions? Yes.
Hi everyone, this is Kashif and I'm from UK Health Security Agency, and we are looking after IDSR implementation in support of HISP Pakistan in Pakistan. So such a wonderful presentation. I just want to ask, like, how you are managing your lab data into DHIS2, whether you are doing in DHIS2 or you have separate system for managing lab data.
Thank you very much for the question. And regarding the laboratory data, we don't have the specific that is a data entering system. Every lab have own system and for the records, and they only reports and they prepare the aggregate data monthly and they enter into the system. They are only reporting by aggregate into the system monthly regarding the lab data. But others different types of data. We have the different types of information system. Some of the system takes the tracker data, individual data, but regarding their lab data, they only report the aggregate data by monthly.
Do we have? Oh, thank you. I'm Dr. Basharat Javed, and I'm working as the M&E and surveillance specialist for the Global Fund projects in Pakistan. My question is that it is more of a generic question, but once the presentation is over from two ministries, that is a question always as a comment as well, that how the data is monitored and validated before uploading into the DHIS. Because otherwise, merely the data would be a number if we do not monitor it and we do not validate it. Thank you.
Yeah, we have a system for validation of the data, and if we suspect the data regarding the quality and their discrepancies, we regularly monitoring the data from different system, and we have the annual monthly the review mechanism in local level and then provincial level as well as in the central level. Then we finalize the data by yearly. That's our monitoring system. Is the system has the data validation rule we use in some specific data elements only. It is not we are not using for the all the data elements. Some elements we are using the data validation rule from the system.
Right, thank you so much. So we see like a lot of questions that are raised from the audience are very practical questions, which are common for all the countries, right? And I think there are a few more pending questions, but we are going to park those questions for now. The reason being, we will let two other countries to present, and then we will have a broader Q&A session, which will go all the way till tea break, so that we can ask and discuss all these relevant questions. Okay. So next, it's my pleasure inviting Ministry of Health, Timor-Leste, please. Yes. We have Mana Natalia, who will be presenting from the Ministry of Health, Timor-Leste.
Okay, good afternoon. Thank you very much. I will be present the progress of the services of the DHIS2 that have done in Timor-Leste. The journey of the DHIS2 implementation in Timor-Leste, we implement since 2013. In 2014, the DHIS2 approved by the Council of Directorate to implement in Timor-Leste. In the next, we are revised the HMIS form. And in 2015, we are customized HMIS form and implement in phase 5 municipality. And then 2016, we are expand to the another 3 municipality. And in 2017, we are implementing the whole territory in 13 municipality. In 2019, October, conduct national workshop on development of integrated health information system. And in 2020, national review of the LHIS or the DHIS2 implementation. Into 2021, in April 2021, we are use the DHIS2 for COVID immunization tracker, and then for the point of entry tracker for COVID isolation center. And in 2022, in May, upgrade to 2.36 revision and develop the training of the model. In 2023, in January, we are implement supplementary immunization activities, and in April this year also we are implement the AP survey. And in May 2023, we are update the form of HMIS based on the indicator that have revised in country. In August, we are use the DHIS2 for deworming, and last October, use the DHIS2 for the ICT assessment. The objective is to support efficient data collection from the facility, timely and complete, to facilitate the data validation process and feedback mechanism and increase data quality, to provide easy access to the data and tools for the analysis, thereby promoting use of availability data for decision, to provide integrated data repository for cross-analysis. The status of the implementation, implemented in all municipalities with over 600 users. Data entry is mostly done at CAC level by dedicated HMIS officer. Continuous refresh training provided to the user. Server managed by the MOH ICT department. Upgrade hosting services September 2019 to November 2021 to accommodate increasing number of users. DHIS2 version upgrade in May 2022 and November 2023 in progress, managed by HMIS Ministry of Health with WHO support. The status of the implementation, yesterday, the user login in 73. This is to show you the data flow. We are catch all the data from the outreach, indoor and then outdoor, to submit to the sub-district, or we can call community health center. And then through to the district health officer, we have the 3 municipalities, to the HMIS department at the Ministry of Health. We not capture yet the private clinic, referral hospital, and the national hospital. Data collection form, we have 23 type of the form, like MTAs, immunization, newborn care, nutrition, IMCI, outpatient, inpatient, reproductive health and family planning, lab services, eye care, mental health, NCD, mortality data, environmental health, health promotion, oral and dental care, TB, malaria, HIV, filariasis, human resource, weekly surveillance, and monthly surveillance. This is the reporting rates that almost 100% from the 23 form. The COVID immunization tracker, daily reporting of number of doses given for the each vaccine at vaccination post level, vaccine type, dose and sex, and category breakdown, vaccine stock information. The recent implementation supplementary immunization campaign or activities, daily aggregate data entry, doses administered by each vaccine or drugs, and by sex disaggregation, reaction by the sex disaggregation, stock information by each vaccine or drug, 100% reporting rate, target monitoring, and infographic. This is the SIA dashboard. For HIS or EPI coverage survey, using digital technology for the first time in Timor-Leste for HIS, individual event capturing using tablet and DHIS2 mobile apps, capturing of location, capturing API and SIA coverage, dashboard for supervisor and then managers. The impact story of the DHIS2 is the big achievement is sustained high vaccination coverage against priority disease by implementation DHIS2, by raising the national vaccination coverage rate from the 86 to the 95%. Deworming progress in the school, implemented in 2 municipalities in August 2023, aggregate data of deworming captured by the school, dashboard of supervisor and then managers. That is the data. For ICT assessment, implemented in all CAC, we have 72 CAC and then 5 hospital referral and 1 national hospital. Assessment of ICT equipment, connectivity, human resource and training status, 76, they are conducting 76 events and then capture all that. To integrate the TB, HIV, and malaria, we have a malaria through the surveillance tools, TB, vulnerability assessment dashboard, and then for HIV/AIDS surveillance tools. Those 3 programs, we aggregate and case investigation and case base to the DLHIS or the DHIS2. Upcoming development, one is the birth and immunization registry, morbidity and mortality data reporting, case-based surveillance in IDSR, school health record, partner mapping module, facility readiness assessment, integration with the other digital health solution. So we have used several e-health at the Timor-Leste. One is the M-Supply. It's almost complete. I'm stop here. Thank you.
Thank you so much. Yeah, you finished early. Right, so do we have any questions for Timor-Leste? They have long-standing DHIS2 implementation and some, couple of innovations which they have already presented at the DHIS2 annual conference as well. Yes.
Thank you for sharing a very unique example of using data collection methodology in DHIS2 templates. In terms of conduct of the survey for the EPI coverage evaluation survey, and it's syncing into aggregate numbers. Did you face any technology-related problems just as a public health person? Because we are talking about routine information systems, aggregate data-based reporting, tracker module, case-based reporting, but use of survey methodologies in DHIS2. Maybe interested to know about that.
Technology challenges when you are doing the EPI survey. With the technology related.
Yes, for the technology challenges is one in Timor-Leste is we have the poor of the poor of the connection is the one, and then second one is the also the infrastructure. It's not only connection but also the what is it the infrastructure, the network, and not only network but the hardware also. Because the Timor-Leste is a small country and then a small health, the small number of the health facility, and then we have a lot of support from the other partner, and then also the government put the priority on that one. So that's why we're pushed in implementation.
Thank you, ma'am, for a very good presentation. Of course, the experience of COVID using DHIS2 during COVID was a unique experience from your side. I have two questions, quick questions. And one question is that, are you thinking, your country is thinking to go on to the WHO TB tracker regarding the case-based data? And the second question is regarding the mortality data, that do you have any mechanism to determine the cause of deaths during your mortality cases in disease-specific mortalities?
Would like to share with you that the progress is have done so far for the TB. One of the advisor from Sri Lanka also is actually now he's working on that one in progress, and then we'll be implement soon after the finalize that one. This is the one. Because the government, as I mentioned before, that for the another 7 years coming, the proposal to the Global Fund was approved for Timor-Leste. We put the money for to strengthening strengthening that HMAS through the 3 program. And then also, as I mentioned, that the government put some money there to strengthening the HMAS, to include, to integrate it all 3 diseases. Mortality data collection, now we are in discussion, in the process to in the discussion, because we are gradually, step by step, to upgrade our to integrate it all the diseases in the DHIS to maybe it will be, I just present disease will be coming, but maybe it's take another 1 year to be reached there.
Any more questions for Timor? Yes, one.
So probably the last question for Timor.
Добрый день, уважаемые участники. Спасибо вам за вашу интересную презентацию. Конечно, наработок очень много. У меня вопрос такой. Вы, получается, DHIS2 использовали в рамках COVID-19 вакцин, да? У вас был ли опыт использования этой платформы для надзора за побочными проявлениями после иммунизации?
Thank you so much for the presentation. As far as I understood, you have generated quite an experience in applying DHIS2 for COVID-19 vaccination, right? And Gulnara from the Kyrgyz Republic has the following question, whether you have an experience in applying or using DHIS for monitoring of AFIS, adverse events following immunization. Do you understand the question?
Yeah, yes, we capture for the adverse. It's by the sex, by the age, and yeah, and then even by the place. So when it's we happen, then the teams will be going to be managed.
Thank you very much. Yeah, I can share some insights about Timor-Leste because I work very closely with the team. So for COVID immunization, they were using AEFI, but then again, because it was a tracker implementation, there were some challenges when it comes to the completion, right? But they are in the process of using DHIS2 for routine immunization as well. And in that one, AEFI, adverse events following immunization module, will be incorporated. Right. All good? Yeah, right. Okay, thank you so much. Right, so next we have a presentation from the host country, Sri Lanka. So let me invite Dr. Ashan from the Ministry of Health, Sri Lanka.
Good afternoon. I'm Dr. Ashan Dunugala, representing Minister of Health, Sri Lanka. Actually, I'm so proud to tell that Sri Lanka was one of pioneer countries who's adapting DHIS2 from the beginning of its journey. Actually, since nearly 2009, Sri Lanka had some DHIS2 based systems, and the other thing is there was a very good collaboration with University of Oslo and University of Colombo, and we had a great opportunity to have some doctors who's doing MSc in bioinformatics to get training on DHIS2 and other things happening on Oslo. So from that time, we had a very good collaboration, and because of that, now we are having very good this IT-based health worker capacity in Sri Lankan Health Ministry, and because of that, we are having some very good innovation, new innovative things in DHIS2 in Sri Lanka, and one of that is we actually involved in most of the developments of this COVID-19 related activities happened with the DHIS2. So one thing we had was this DHIS2 and DIVOC integration. So we could integrate this DIVOC system and DHIS2, and because of that, smart vaccine certificate issuing we could do. Still that thing is happening, and still the people who are migrating from the country, we are issuing smart vaccine certificates through this system, and almost all the adult population in country have been registered in this COVID-19 vaccine system. And actually it was a very big asset for our public health system. And in future, actually, we are trying to use this database as one of our major central database, and linking it to other public health activities. And with COVID-19 system, there are some custom-made applications related to DHIS to make in the country. So one of that was COVID-19 ICU bed management system. There was a very big need for identifying ICU beds in the country, which beds are available, what are the facilities available in that institute, what are the specialties available, those things we needed to know. So those things easily a doctor can find those data by using this application. It used both aggregate and tracker modules combined, and we could use this data to book ICU bed, see what are the reserved ICU beds, and those things we could use. And our newest development is this diabetic compass. Actually, it's a Fire Core app, and it linked with DHIS2 for data aggregation. Actually, it's a multi-platform integration is there. So all those things are linked with fire, and now actually this thing is in practice. It's a app for screen diabetic people, diabetics patients in the population, because it's a very huge problem for Sri Lanka. Nearly 20% of adult population is having diabetics, so that non-health workers are going to the field, and with this app there is a screening questionnaire. So this app will give a score, and they can identify the people with high risk of diabetic, and then they can refer them to diabetic clinics, healthy lifestyle clinics, and other facilities available. So actually DHIS2 is using for aggregate these data captured from this application, and it's a the use of fire profile is the major thing we need to discuss when we are talking about this application. And then district nutrition management system. This system is actually for the field level malnutrition data capturing. For all the under 5 children's data we are capturing, and other than that, the malnourished children's data we are capturing, and those things we can follow up. And the other thing is this DNM system is not limited to health. So we all know the nutrition is not only a health problem. There is poverty and various factors are affecting for nutrition. So this data can pass to the other stakeholders with the permission of that area medical officer of health. So medical officer of health can pass this individual children's data if this children's issue needs to be addressed at a different department. So that part also included into this application. Then we have very good aggregate data implementations in Sri Lanka, especially this ERHMIS system. It was there since nearly 2017, and in Family Health Bureau, its a major component is maternal and child health monitoring. So other than that, school health, then environmental and occupational health, oral health, nutrition data, then this there is Health Promotion Bureau, this health promotion activities and all the things, those things data also we are capturing. Then some of logistic data and human resource related data also captured through this system. Actually, it's the aggregate one. So in this single system, there are 3 major stakeholders in Health Ministry, Family Health Bureau, Health Promotion Bureau, and Environmental and Occupation Health Unit of the ministry. They all share same DHIS2 instance, and they are capturing their data through this system. And we have various tracker programs. This is anti-leprosy campaign, they have a tracker program for individual data capturing, and still actually this was implemented very recently. A few weeks back, actually, they completed a national-wide implementation. So they are in progress of this contact tracing. That part they are trying to develop. The patient's data and all, they have the individual patient data capturing. Those things they have included in this system. Then anti-malaria, actually malaria almost eliminated in Sri Lanka, no local cases. So they have this aggregate and tracker, both programs in place. Aggregate program is for the screening process, mosquito screenings and all. The tracker is for patients, but very few, nearly 20 cases. All of those are these foreign travelers and all. Those cases are coming, we are getting in our country. So those data we are capturing in this tracker program, but it's usually very few stages because it's not a very big burden at the right moment, at the current moment. And we have this mental health data management. This one also an aggregate one. So the mental health diseases, people are attending to mental health clinics, their aggregate data they are capturing, so that the disease distribution and burden, all those things we can identify. Then for TB, our major system is aggregate one. So there is aggregate TB information management system is there. Actually, we might need to go for a TB tracker in future. The major thing is now our hospital-based systems are developing, and implementation is countrywide level is happening, so that what we are trying to do is capturing that data directly from hospital level. So our systems also might have to little bit change in future. So in way forward, there is National Digital Health Blueprint is in place in Sri Lanka. So there is an integration plan, and those things are there. So our major problem is in DHIS2, our information systems are actually in information silos. So two systems are not talking to each other. So one thing is we need to do this integration of DHIS2 systems. The other thing is, especially using these fire profiles and all, we have to link DHIS2 systems, especially to hospital information systems and all. So those things are in place. As I told you previously, these diabetic compass and all are happening. So these fire profiles and all the things are currently in place, and I think we are moving forward. Thank you.
Right, thank you so much. So many different systems, Dr. Ashad. I think the audience must be surely having some questions. So who wants to go first?
Thank you so much. A really very impressive presentation from the Ministry of Sri Lanka. And they have almost captured most of the major communicable as well as non-communicable diseases in their dashboards. And they are perhaps longing for a common dashboard for all the diseases there. My question is that whether they have included the private sector, private health sector in that dashboards or not? Thank you.
Yeah, in Sri Lanka, actually, for public health, major contribution is from government sector. And so that actually for public health part, I think there is no very big need of adding this private health sector. But
private health sector, there are some contributions, especially for deliveries and child immunization care and everything. For those things, actually, we are in progress. In progress means for maternal and child health data, actually, we are capturing that data into our government system. So hospital-based data system is there in place. So all the maternal deaths related data, neonatal deaths related data, all those things, actually, currently also we are capturing everything, birth data, everything we are capturing from private hospitals. Immunization data also, actually, we are capturing through that system because our there is common child CHDR, child development record is there. So that data we can capture even though they have vaccinated in private sector, that data can be get from Ministry of Health through that record. So
in short, like you have MCH data, even from the private sector, you are
private
getting
sector,
into the DHIS2 system.
that's there.
We're talking about Ministry of Education as well, because there was a software that you were showing where the education and health were working together. School health. Yeah.
ERHMIS,
So,
yeah.
we used to have a school health system which was now non-functional. So, what were your successes and challenges in bringing the education sector along with health?
Should you ask the question from the correct person, because he was the one in the ministry who was in charge of running the school health system. So please go ahead.
Yeah, actually, my MSc was on school health. Yeah. Actually, it was a very big challenge during that time. But what we did was we gave separate access to education ministry, and we created separate dashboards, and we try to keep them in touch. That is what did in the higher levels. And the ground levels, actually, in our Ministry of Health, the Ministry of Health officers area, there is some returns going to the regional education officers and all. So we at that time, this paper-based returns were it takes some time to develop, and they are actually even though it's in process, the procedure was there, it's not happening. But due to this ERHMIS system, all those reports, they could generate very easily. So that once these reports were generated monthly or quarterly, once we are sending them, then actually we had a very good collaboration. And actually, for this school medical survey and school medical inspection, two parts are there. In education ministry side also, they are doing same thing. So actually, we were able to manage some collaboration with these two people, two parties, and do these things together. So that I think it's happening pretty good now.
Any more questions for Sri Lanka?
Thank you. Just want to ask you, since you're one of the early pioneers implementing the DHIS2 platform, to what limit do you think you have implemented all of the features brought by this platform? And the other part of the question is to Mr. Ola. Have you been you've been monitoring the countries that have been implementing DHIS2? So have you seen certain countries that have implemented all the features of DHIS2 to its final capabilities, and they request more and more additional features? Thank you.
Really interesting question. So I think you will go first, and then maybe Ula. Yes. So
Yeah.
how much of features of DHIS2 are you using in Sri Lanka?
Yeah, actually, we started from DHIS2 this aggregate modules. Then, especially this data quality-wise, the features we need, the validations and all, actually we were very focused. And some of the features available in DHIS2, especially some of things like WHO data quality tool and all, those things are still not in place for all the systems. So that part is there. And I think for DHIS2 tracker, most of the systems moved after implementing DHIS2 aggregate module if it is relevant, because we have a very good healthcare workforce who's working with DHIS2 aggregate modules. And because of that, actually implementing aggregate modules are very easy. And now only actually after this COVID-19 pandemic, we are using DHIS2 tracker largely. And as almost all the healthcare workers, even they were working in other departments of the health, we had to use them for our COVID-19 data entry works and all. So that I think most of the healthcare workers are now familiar with this DHIS2 tracker features too. So that now we are in a position to move for DHIS2 tracker and use other things.
Yeah, I can try to respond. I think obviously it's impossible to know about everything that's happening. But as I mentioned in my presentation, we have a big network of the HISP groups. You know, Pamod here is obviously very active in Sri Lanka and supporting many of the neighboring countries. So through the HISP groups, we try to kind of keep getting updates from the countries on feature requests and what they are doing, also to be able to share innovations, share good examples, and also challenges throughout the network. We do have a little bit of public information available in terms of tracking, or let's say keep track of what countries are doing in terms of the different health programs, both when it comes to aggregate data and also patient level data with tracker. I don't think I shared those links in the morning, but we can definitely share those. And the map you saw on a few presentations this morning, that's interactive. So if you go to DHIS2.org, you can look at maps, and you can do it kind of by different areas within health and also other sectors, and see kind of which countries are using what part of the system. I think when it comes to individual features, I don't think there's any country that uses kind of all functionality. But if you combine all the 80+ countries, yes, then you will see that they are. And I think Sri Lanka is a good example where they pushed us a lot during COVID, especially in the early stages, where, you know, starting with surveillance before any other country here. And during that period, you know, they were really pushing us, and the team working on tracker, the team working on you know, performance, managing large scale kind of patient level systems. So there's always countries that will push us forward in one direction and another country in that direction. So Austin and the team are very busy, as they say, trying to catch up with all the requests coming. But I think conferences like this, and also other regions, and the one we are doing in Oslo every year, is a great place to be able to kind of hear from what countries are doing and you know, learn from each other. So and I think Sri Lanka is one of the more impressive in terms of the wide range of use cases where they've applied DHIS. But then maybe they have some areas where they can do more in terms of integration, interoperability, and that's on the plan now as we hear. So yeah, and I'm happy to show you some of those references, and maybe we can do a slide towards the end of the conference and share more on those kind of publicly available registries of what countries are doing with DHIS2. Thank you.
Yeah. So one final question for Sri Lanka, and then we are going to open up for all the 4 countries. So it could be for Sri Lanka, Nepal, Pakistan, Timor-Leste. Yeah. Okay. Sir? Oh, yes. Yeah. So the question. Yeah, that question has already been answered. So, okay, now we have 10 more minutes or 8 till the tea break. So we can ask questions from all the four presenters, not only the presenters, all the four countries. So we have Pakistan, Nepal, Timor-Leste, and Sri Lanka. Yeah, so Hanan, yes.
To Sri Lanka first. So you mentioned that all the public, the government facility, public facility is take care of the most of the data. Private is comparatively less participation. But the health economics data actually showing there is a lot of public-private participation as well, specifically on tertiary care, non-communicable disease and those specific areas. In Bangladesh, this is huge, almost 60-40%. So in my country, it's 60%. Sri Lanka is much less. But my question is, do you have any larger activities with your private facilities like NCD, specifically for hypertension, diabetes, and those area, not primary care level, as a tertiary care level, those data is integrated and find the disease burden of that. Because some cases for Bangladesh is actually going very high. So this actually become the top 3 causes of death is the NCD.
Yes, I think actually it's a very good question. In private hospitals and other government hospitals also, this NCD and all the disease information capturing is a very, very huge challenge for us actually. And that is why in our national EHR electronic blueprint, actually, there is a way to link all these government hospitals, private hospitals, and our public health institute together. So now also we are capturing this mobility data and some other data from our private hospitals. The major problem in our private hospital sector, actually, the most of the time, this treatment is counseling, not the primary care level. The treatment taking is the major contribution, and hospital stays and all are there, but I think it's less than 5% of total like. So nearly 95% of hospital admissions are into the government sector hospitals. So only less than 5% is private sector. So, yeah.
So let me also contribute by adding something. So let me ask all of you, right? So the thing is now NCD data, right? Especially in the private health care sector and I mean curative care sector. If I ask from all of you, can you implement DHIS2 across all hospitals? It could be private sector, public, preventive campaigns. Is that a reality? No, right? At least in Sri Lanka, it's no, and most of the countries we are implementing, it is a no. So that is why the Ministry of Health, Sri Lanka, is coming up with this concept of implementing digital health blueprint. So what they're trying to do is some of the data which is already captured by other systems. I mean, some systems, especially in the private sector, has been there for decades, right? So there's a lot of data and it's just stuck in their systems. So what they are trying to do is not to introduce DHIS2 as EMRs, electronic medical records, for example, or hospital information systems, but whatever the relevant data to get into a central repository. And if the NCD unit of Ministry of Health is using DHIS2 to think of a way how we can plug or connect that private sector information, which is captured in another system, to DHIS2, which is a more realistic or practical approach. So that's why all the work that Dr. Ashan was mentioning about establishing FHIR as a data exchange standard and then connecting all the existing systems becomes very crucial, because that's a more practical approach of connecting system. But of course, technologically, it's challenging. So they are still in the way of kind of finding the correct way of doing that. Yeah. Any more questions for any of the countries? Oh, yes. I think Dr. Dagani, yes, just, yeah. So the question is, what is digital health blueprint? Oh, yeah, I will, because it's a follow-up question. So I will briefly answer. So yes, it is not just a policy document, but it goes into a little bit of technicality on defining technicality as in like not from technology perspective, but when it comes to data, from a data point perspective, a technicality on how different systems should be integrated. I think if you talk to Dr. Ashan, I mean, I'm not sure like how much of the document, because it's still underway, is shareable, but certainly there must be something that you can share with other countries as well. Yeah, okay. So many questions. So should I, yeah. So Dr. Dagani first, I think from Libya, and then, yes.
Thank you very much for all the presenters. My question is very simple. We are producing a lot of data with information. My question is how these 3 countries or 4 countries can evaluate the use of this information at the ministry level or at the decision makers level, because they are always seeking information. We are always producing information, but they are not happy really with our production.
Specific country or? So open question for all 4 countries. Who wants to answer? Yes, Pakistan first.
I think I'll just maybe touch upon a few features we are trying to use in Pakistan for promoting use and then also to somehow document it. So we have a common national level dashboard for all the information systems coming together, pretty illustratively showing the progress and the trend lines from the past till current times through information systems, as well as in relation to the surveys that are conducted in the country. They don't seem, and we are tracking on the number of users who have reached the site and the types of users as well. So the users at times have to fill in a small annotation that they're a manager or researcher or academician or that sort of thing. So that is one passive way of doing it. The second part is that we have these regular reviews conducted with the provinces, given Pakistan has a devolved system, and in it we display the use of data as well as how they can further enhance on it. So it's a constant engagement mechanisms with the provincial higher managers as well as at times with the district level people. In the DHIS2 phenomenon tracker modules for tuberculosis, malaria, and HIV, we also have these tracker-based manager use, implementer use components as well. So just to broadly answer how we are trying to push, but definitely it is one area which I think we as a country can do much better to improve decision making and strengthening of, even for example, the logistics systems and how the supply chain is working. That has to be reviewed, presented, and then decisions taken, and then the logistics mechanisms of procurement adjusted as well. So that is one example as well. Yeah.
I think we are producing annual reports like UHC report, vital sign profile, using this routine data. Yes, then weekly surveillance reports that comes in the form of bulletin, which has a monitoring element impinged in it, where they review it and see what kind of disease are coming up during that particular week, or like we have dengue, I would call a season more of a dengue season, and then malaria, and then acute watery diarrhea, and then some few of the cholera breakout came and were caught in time rather than, you know. So we are producing such kind of reports, which, I showed just the national picture, but there is also a provincial and district level actual breakdown picture in the whole report. So we are using those data, because unless you don't use it, it's just numbers. Yeah, thank you.
Okay, in Sri Lanka experience actually, Sri Lanka for data use, actually there was a very good paper-based this reviewing mechanism from the beginning. I think our public health information systems are these paper-based things and all are nearly 100 years old. So things were in place. And what we did was we tried to replace those systems with our electronic systems. So we actually conduct all their review meetings and all the things based on report generated from our electronic system, so that they had to more accountable on the data they are putting in the system. Because in reviews we are asking, so there were regional reviews, monthly reviews, quarterly reviews, annual reviews, those type of all the reviews were there. So in central level for some systems, especially for ERHMI system, we created dashboard only for these reviews. So for these reviews, all the charts, graphs they needed to present, generate in that special dashboard, so that they do not need to create special dashboards. They do not have to download data and create graphs or charts using Excel. They just have to use DHIS2 for these reviews, so that they can't manipulate. If they are using Excel or something like that, they can change data and they can show something else. But because we are using same platform in national level and regional levels, they had to use same data, and they are now much more accountable for the data they are putting, so that actually because of that, the data quality also improved, and their data use also improved. Other thing is, always we try to help them, their works, while developing systems, so that they are all the, as I told you previously, the medical officer of health has to send a report to education ministry, so they can develop that report using this system. There are some returns they need to send monthly. All those reports they can generate through this system, so that their works also getting easier. Because of that, they are using system more and more. So this type of things we did, I think it helps more.
Right. So data use is kind of like the question that all the countries are having troubles with. So let us ask from a, not only an expert, like an expert with decades of, research on data use. So Prof. Yon, what do you think about, like, what are these challenges, and how do you think the country should address all these issues?
Yeah, no, data use is that's should be the motivation for collecting all the data. So data use is important, and we have for some time tried to work on getting approaches and methodology to establish routine data use in countries. And the original idea for how to do that came from Indonesia, where we had a project on data use for some years back, and we were working on how to use data at the local level, at the district level, and at the facility level, and how you could use dashboards. Because in Indonesia, as in also many other countries, they have a strict routine that every month they have a meeting where they are using data at the facility level. So our idea was then to support these meetings with dashboard, data reports, so that they actually could use the data. And the idea and approach was then to say that you have a certain number of indicators covering the different program areas which you have planned for annually, and then switch between these indicators. Say every 3 months you come back to the same, and then you have say human resource indicators, you have disease prevalence indicator, you have mother and child health indicators, and you switch between them. And that is an effort we have tried to do also in courses we have in Africa. And now we are also starting a round of training in information system, a bit at the academic side. It should be useful for people from the ministries working on DHIS, but also for those who would like to maybe take a PhD and engage more into research. And there we are having a 1 week workshop, 1 week course. We had one in East Africa, in Rwanda, a month ago, 2 months ago. And now, 2 weeks from now, we will have in West Africa, and in around February, March, we will have in Asia. And we expect a couple from each of the countries that are here to participate in that course, and more information will come later. And what we are planning to do is then to have, for those who are participating, say the HISP groups and friends in the different countries, they do a research project on data use before the course. And during this 1 week workshop, then, which is quite intensive, we discuss and look into how the challenges that they found regarding data use before the course, how they could be addressed, and then after the course, you go out in the field again and try to solve the problems. So that is the idea, and that's also the template we're thinking to use for data use. Go out in a district or facilities, look at what are the challenges, why are you not using data, why are you only reporting to high levels and not using it yourself. And then we will find out that, oh yeah, no, but we don't have the data, for example. Okay, then we must help them to get the data. And if that could be the first step, then we can later see if that solved the problem, or the next problem would be maybe it's not the right data, we need to quality data, etc., etc. The point is that we go out, address problems, challenges, and we come up with solutions, and we see if these solutions are working later on. And we can continue such a cycle forever. At least we can do it next year as well, and we can continue with that. So that's our approach to data use, and I hope all of you will join us for this exercise.
Thank you so much. I know there are a couple of pending questions, but the time is 3:10, so we only have 20 minutes left in the tea break. But before we break for tea, one question. Have you all joined the WhatsApp group? Is there anyone who has not joined the WhatsApp group for this conference? Yeah, I know like there are 92 or last time I checked, 92 people have joined. Yes, 94. Okay, great. Yes. So one other question. How many of you want a certificate for attending this conference? All right. So the thing is, for us to issue this certificate, we need to know how your names should appear on the certificate. So in this WhatsApp group, we will be sharing a link for you to fill up a Google form, right? So how to get a certificate? First requirement, please complete that Google form. Complete all the information, which is very important for us. So not only to issue the certificate, but also to share the conference material, because we will not be issuing conference material individually to all of you. We will be uploading it and sharing with all of you. For that, we need some information, including the email. So it's a priority. So please, all of you, kindly fill in that form, Google form, so that your certificate will be ready. And also you will be able to access the promotional material. Okay, with that, we can break for tea. The tea is served here in the foyer area, and we will start again at 3:30. Thank you.